Morning, Musa, or evening, Musa. It's the evening. And what do we do? We're doing Thinking Around the Question again, which is our podcast where we look at questions and we look at issues and we try and go a bit beneath the surface. We look at stuff that's in the headlines or stuff that matters, and we try and develop a conversation around that, which is the conversation which is out there at the moment. And it's the company of how we do it. I mean, there you are, Musa. You're a psychiatrist. You come with that background, and as you remind me constantly, you also experience life as a UK citizen who's Muslim, and that affects your way of being in the world. And here am I. I'm a social anthropologist who is a bit curious and questioning. And between the two of us, a conversation develops, which often I leave thinking very differently to the way I came in. So I'm going to ask you, which I always ask you, what would you like to talk about today?
Oh, okay. Jonathan, we've probably discussed this offline quite a bit. It's been coming for a long time. Um, you know, there's an inquiry going on in Nottingham. It's the town in which I live, city in which I live, into the killings of three innocent people, and the attacks by a person called Valdo Calocane around 3 years ago. He was an individual with schizophrenia who had been discharged from mental health services, and around 15 or 18 months after that, in what appeared to be a random, unprovoked attack, one night he caused carnage throughout the city. It was mayhem. Now, the um, most British citizens, most British people will have heard of this story in some way or another over the last 3 years. It's constantly been in the press. There's been lots of failings that have been identified. There's a inquiry that's going on called the Nottingham inquiry. Lots of things are coming out in that inquiry. The police, the university, the hospital trusts are being held to account. And I don't want to talk about the inquiry or the evidence which is going on so much just yet. Um, Although perhaps it's in my mind at the moment because the mental health evidence is going to be given now. So
What's given before the mental health
oh,
evidence?
there's been a lot. I think we're on week 7 or so, and there's been stuff by the university, by the police. There's been lots of failings. There were lots of failings around it. In how he was managed, how he was treated in custody. There were some failings in terms of voyeurism by professionals, by police or hospital staff, and others into looking at the pictures and images and the data of the victims. All of these kinds of things. The whole thing became a bit of a mess. But now they're going to get on to my profession is now under the spotlight for the next few weeks, Jonathan, and it's. I mean, I've got a feeling it's going to be carnage for my profession. We're going to go through a very very difficult time.
That
But
that
I,
that's that sounds like a sports commentary in the making. So why do you
hmm,
think it's going to be carnage?
I think that because there's failings, I think there's some failings. I think there's some misunderstandings, um, and I think that it's not going to be pretty. I don't know at the moment, Jonathan. All this stuff hasn't come out, but I am a bit worried for my profession and the standing of my profession, and how the public is going to perceive us. However, I am interested in thinking about why now. Why are we thinking about these things now when some of the issues that are going to come out have got very long standing roots? And this is not the first time that the issues that are going to be raised have ever been noted.
Well, let me tell you what I see of mental health in the news.
Sure.
So we got if we like acceptable mental health, which is people talking about the problems they have day to day. So this articulated mental health, this way of saying, look, I'm now going to look after myself, which is quite a recent development. But this way of doing it. But we have this other mental health story, which is about the other, the crazy, the insane, the lunatic, the schizoid, the whatever we want to call them, the extremist, whatever label, and we handle that very differently. Uh, and I'd really like you to sort of talk about that because, in a sense, mental health, and it's a very broad church, has
Yeah.
been, as you say, has been around. Well, you're going to tell me for how long it's been around, but these cases occur occasionally. I mean, they have done as long as I've been growing up. They do occur once in a while, and I'd like to kind of understand how we see them and how we could see them. So, can I start with a question?
Hmm.
How old is mental health? How long has these issues where someone's you know been in such a state they've violently hurt people? How long has that been around?
I think that's as old as human civilization itself, isn't it, Jonathan? I think nobody has any questions about that.
And just to
Um,
get this into
mm.
context before you do that, how many people with mental health problems present violent behaviour towards others?
The official statistics, I remember going, this goes back a few years. I doubt that it's changed very much. For every first episode psychosis presentation, for every 500 cases, 500 to 600 cases, there will be one homicide, right? Whereas on the other hand, for anybody who's diagnosed with an enduring psychotic condition, they have 5 to 10% likelihood of dying by their own hand, which is a massive. That's just massive, you know. And you can think of suicide as violence turned inwards, isn't it? So
Yes.
the violence can be there. You know, it's rare, and it's rare to be to others. Sometimes it's just horrific and very dramatic when it happens, but
But
it's rare.
for anyone
Yeah,
watching this, because we're about to discuss it as
sure.
if it's happening all the time, what you're
Yeah.
saying is actually we have these rare cases that happen once in a while where this happens.
Well, it depends how. Well, I suppose it depends what you and mean by rare, as I'm going to talk about.
Mm.
You know, the one of the seminal or really important cases of mental health, of violence and mental health, was the killing of Jonathan Zito by Christopher Clunis, which led to a national inquiry in 1992. So that's some 34 years ago. Since that time, there have probably been 300 or 400 similar incidents. Um, it's not small. That's rare in a country of between 55 and 70 million people, depending how you count it. It is rare, but it's not trivial. It does represent a large number of individuals who have died at the hands of someone with a serious mental health condition.
And can I get a sense of how many people have died at the hands of people without serious mental health conditions?
I think it's really difficult to give you complete numbers for that. But what I can say is that I think there's around 5 to 600 homicides a year in this country.
Okay, and so how many mental health homicides are there?
But I think it would be difficult to say. You know, I think that the stats that I know, I seem to remember, is that you are most likely to die by somebody you know rather than a stranger that you don't.
Mm.
Um, and yeah, mental health homicides represent a significant proportion, but it's very unlikely that any individual with mental health will go on to kill someone else, although it does happen.
And I want to just cover one other thing. You talked about failings in the report, or in the inquiries. There will be
Yeah,
failings.
there'll be failings.
Whenever this happens, are there always failings?
Oh, there are always failings, Jonathan. Huh? Was it to err is to be human? I mean,
Mhm.
then the inquiry, the scrutiny of any serious untoward incident. I've never known a single inquiry, whether from a hospital or anywhere else, which has said there's no failings, there's nothing to see here. Right? There's always some failings identified. Sometimes it's the right ones, sometimes it's the wrong ones.
Okay,
Yeah.
I know some things I want to find from you, because
Yep.
I kind of want to find, and I'll sort of list them out as I go. But I mean, I kind of want to understand what this diagnosis is for people who end up
Okay.
doing this. I also want to get a sense of a sense of how the psychiatric profession understand these incidents. And by the end of it, I want to leave with a sense of how I should see these incidents and how I should understand the reporting of these incidents. Because as we constantly come back to in these conversations, when things are reported, they are doing so in a particular way, and they're missing most of the story and promoting other aspects of the story. So I'd really like to grasp those things, and other questions will come up on the way. Are you okay if I start with what you've just described schizophrenia, you've described violent schizophrenia. What are these things?
Schizophrenia is a diagnosis of a type of psychotic disorder. You'll have heard these terms quite a lot, isn't it? You'll have heard, I'm sure, psychotic, psychopathic. This is a term that scares us all, isn't it? Right? But this, just pare it back a little bit, right? Psychosis is a state of disengagement from reality. It's often thought about as, often described as something like false inference or reality distortion. These are the two terms that are often used to describe usually three different types of symptoms, right? Any one of those three, right? One is a hallucination, where you have a perception of something, such as a voice, which is not there in reality, or such as a vision, where there's no stimuli there's nothing presented to see. Um, that's a hallucination. The other word is delusion. So that's tends to be a belief, which is held with something called delusional conviction. One is absolutely convinced of its truth, which has no evidence behind it. So for example, a man believing that his wife is cheating on him without any evidence for that, right? And this is a classic example often given is that one's wife might be cheating on them, but the point is, if they don't have any evidence for that, even any basic supposition, if they could just smell it, for example, from the bed sheets or these kind of things, that's delusional, right? Yeah. And then the third thing is something called thought disorder, where there is a confused form of thought, where things don't come together in a quite coherent way, right? So this is usually what's meant by the word psychosis. Psychosis can happen in lots of different conditions or lots of different states. It can happen when we're sleep deprived. It can happen when we're intoxicated. It can happen when we're taking too much cannabis. It can happen as the results of an illness. It can happen as the results of dementia or other things. There are certain conditions which predispose to repeated episodes of psychosis. Schizophrenia is one of them. What I've told you about, I'm just going to finish the story here a bit, are what's called the positive symptoms of psychosis. That's something additional that's happening. What we often find is that there are also negative symptoms of psychosis. There are things that we don't do when those things are happening, or in between episodes of psychosis. We can become socially withdrawn. We can start speaking less. We can find our mood to be flat or to have less reactivity. So, schizophrenia is usually seen as a recurrent psychotic disorder with usually, although this doesn't always happen, the functional deterioration in between. And therefore it becomes a very, very complex picture.
Okay, so what I understand is you've got these three positives of hallucinations, of voice, vision, maybe even
Yeah, yeah,
tactile or
sure.
something. You've got delusional beliefs which maybe they're true, maybe they're not, but there's no grounds for them to be true.
Sure.
Other than, and you've got something which I didn't quite understand: thought disorder, where there's confused patterns of thought. What would be a confused pattern of thought?
So there are certain symptoms which have been written in the textbook, such as word salad, such as not being able to follow somebody when they're talking. There's a disjointed nature in conversation. You can often pick it up when you're speaking to an individual. Thought disorder is a disturbance in the coherence of one thought leading to the next, leading to the next.
And what's a word salad?
When you're speaking garbage, you just
Oh, just random thoughts. They're not.
yeah.
Okay, that's a word salad. And then you've got this withdrawal where, personal hygiene perhaps and flatness and less social speaking happens. And does that make any form of psychosis, or is this just schizophrenia?
That makes any form of psychosis. Then how you decide to diagnose schizophrenia, and this will come up in the inquiry, I'm sure, is whether you see other aspects as well. Do you see repeated episodes of the psychosis? Is it in the absence of taking drugs? Is it in the presence of often functional deterioration or negative symptoms? Are there other mood symptoms which might better account for a better diagnosis that fits, such as bipolar affective disorder? You can have psychosis in bipolar as well. You can have psychosis in depression as well. This, called depressive psychosis, right? So it gets very, very complicated, and part of the complication is just people get really hung up on this point. It's just a human. It's just very human to be unable to put people into nice little categories and pigeonholes where we would like them to be. Is this schizoaffective disorder or schizophrenia or psychotic depression? And sometimes, if I turn around, Jonathan, I'm just blunt. Sometimes I say, it doesn't really matter. I'm going to treat it anyway. People find it very, very difficult to to manage or understand that. They want that nice label. If somebody
So,
goes from a diagnosis of bipolar disorder to schizophrenia, they're not going to be your friend. Yeah,
so what I'm not. I mean, we could take this in many different
of
directions. I'm,
course.
I'm not going to start unpacking the process of diagnosis or the DSM or whether medics should have the authority to judge these things. Another day. Let's try and understand it for what it is before going there. I've heard the term paranoid schizophrenic. What does that mean? Or is that just
Yeah. It's an extension of the point I was just making. There were originally 4 types of schizophrenia which were diagnosed. Not originally, but this goes back to ICD-10, perhaps earlier. In the 1970s, there were 4 types of schizophrenia. There's a study called the ISIS study. They talked about 4 types of schizophrenia. One was paranoid schizophrenia, which was the most common. One was called hebephrenic schizophrenia, where there were symptoms of disorganization or more of that confusion, the thought disorder I was telling you about, right? It was bizarre. You couldn't make sense of it. There was something called catatonic schizophrenia, which is where you have movement abnormalities alongside the psychosis. And then there was also something called simple schizophrenia. Simple schizophrenia, you didn't get the positive symptoms I was telling you about. You just got the negative symptoms. Simple schizophrenia was rare, but really important conceptually to understand that you didn't always need to have the hallucinations or delusions present to make a diagnosis of schizophrenia. Ultimately, those what are called subtypes didn't retain any validity. We ended up diagnosing everybody with paranoid schizophrenia in some form or another, and it just stuck, right? So I think the media particularly liked the idea of paranoid schizophrenia, and that's problematic. So now we've stopped subtyping individuals, and we just say whether it's schizophrenia or not. Does that make sense?
Okay, so there's been a development.
Yeah,
This is old time terminology.
yeah.
Now, when violence occurs, and there's, as you say, there's two types of violence, really: violence inwards towards the self and violence outwards towards others, of which the violence inwards towards the self is far more prevalent and quite worryingly prevalent, and the other one is less prevalent but has even more dramatic consequences because a suicide maybe affects one person and they're sort of part of it, whereas the others, in your phrase, are totally innocent. I don't know if that makes the suicide guilty, but I don't think it does. But there's this separation. So
Mm.
let's look at it. Let's start with the violence towards. When does that occur, and what's that about?
When I was a psychiatric trainee, let me tell you of one case that I had, which really illustrated this for me. I was on an acute ward, um, and I got a phone call that there's a patient coming from the intensive care unit. He's been under the intensive care unit, then under the HDU, and then under the medical
So
unit,
what's the HDU?
the high dependency unit, in one of the big London hospitals, and he's coming to you. And his story, ultimately, they sent me all the information. This was a chap who had a psychotic condition, you know, who had stopped taking his medication. He had relapsed. Um, he was he was quite a hard guy. Um, he was very big and very intimidating. Probably used some drugs as well. He had had this relapse. He thought that his employer was after him for some money that it was a delusion that he hadn't. He had swindled as a builder. He had gained this whole delusional system. His employer was going to persecute him, so he had these what's called persecutory delusions. He took a knife and stabbed himself in the chest. Big guy, huge guy, the guy kind of guy I would be really intimidated of. He then developed something called a pericardial effusion, which is it's extremely difficult to give yourself a pericardial effusion, which is the lining of the heart is bleeding into the lining of the heart, and then that was constricting his heart. And then he ended up in ICU, and all of these kind of things. They kind of sorted him out. He was still mentally unwell. They took 10 weeks, and they did an amazing job. That they sent out him to us, right? Um, and I was just remembered. He was a fantastic player of chess, by the way. I used to have great games of chess with him, on the ward, right? I think he had some manic features as well, so he used to really enjoy that with me. But I just remember, everybody would be intimidated of this guy, but his violence had turned inwards. He hadn't thought of going and intimidating the employer that he thought was persecuted him. He just couldn't cope. He could not manage. And it's often in that acute distress of psychosis when you're not quite sure of what is going on, what reality is, the uncertainty that really bad things happen. Acute psychotic relapse is an extremely dangerous, anxious, worrying state. And in that, if it's not appropriately contained, there can be worries to oneself or to others. And there's an element of anything could happen.
So what is it when so what you're saying is it's in that state of confusion that it happens, or have we any sense of what that state is, where that they go from just confusion into a violent act against themselves? Have you any sense of what that
Okay,
is?
this is one story that I've told you about. I'm gonna just talk about that for a minute, and then I'm going to develop it a bit further. If, Jonathan, you believe that people are out to get you, if you believe that you are going to suffer terrible, unspeakable atrocities, if you have lost touch with reality so that you cannot be tethered back to or reassured back to a more settled or more stable mental state, right? Then your delusional system can develop, and things which seem completely irrational to everybody else will internally seem very, very rational to you. Does that make sense? So
Yeah, that
that's
makes
why
perfect sense.
That's why acute psychotic relapse can be very dangerous. Another kind of violence against the self, which I've seen, unfortunately, I've seen suicides from this as well, is in the kind of what one could say is the burnout phase. Or so somebody has done something in psychotic states which is very embarrassing to them. You know, they may have taken all their clothes off. They may have been very sexually disinhibited. They may have, I had an individual who had a manic psychotic relapse, and he'd slept with somebody else's wife, and these guys, he couldn't forgive himself. This stuff happens as well, right? And that
It's a
can then
shame.
lead,
There's shame
shame,
involved.
absolutely. That can lead to what's sometimes called a post-schizophrenic or post-psychotic depression, and that can be really, really difficult to manage.
Can I just start one thing? Because you mentioned it twice. The acute schizophrenic relapse. Why is that in itself more dangerous than the first episode?
Yeah, that's a really interesting question. I suppose uh, it's just a matter of what I see, Jonathan. Right? You
Mm.
know, it's I see. Of course, I've seen people who have had their first episodes. Right? You know, um, but basically, a third of people who have the first episode, they just get better and it never happens again. You treat them for a short period of time, they go away. Um, a third of them kind of remain somewhat in the middle. This is called the rule of thirds. You know, you need to treat them again and off repeatedly, but they're okay. And a third of them, they just don't get better, right? And they can become very chronic and very difficult to deal with. That third, you know, they're the people who often remain in services. You see them again and again. They become what is called revolving door patients. You know, they will often have inpatient hospital admissions again and again. And that's the most troubling and difficult group of patients to often treat or get on top of. And when I say that acute psychotic relapse, that's a lot of what I've seen.
So, and can I add two more questions?
Of
Uh,
course,
at what age do these sort of things start to develop? And are they more prevalent in men and women? Are they more prevalent among some groups than other groups?
I think it's slightly more prevalent in men than women.
Right.
It usually happens, it's really interesting, between the age of 17 and say 38. It's unlikely to happen after the age of 40. And it's unlikely to happen before the age of 17. There's something about brain maturity um, there. Occasionally, you see another peak happening in older age. So there's a particular condition called paraphrenia, where we see this in people, you know, above 65 or so, who, for the first time, they've never had these issues before, or they may have been always a little bit suspicious, right? But it really flares up in the old age, and that might be the old age, the changes of old age, kind of unmasking something that was latent there.
So, the next question, I'm going to come back to the violence, but I'm setting up in a particular way.
Sure.
Does society have a duty of care towards these people? And if so, what is that duty of care?
You tell me that, Jonathan.
Well, I'm leaving it open. I mean, to me, I mean, I've got my own personal answers on it, but is it from your professional point of view? I presume you think there is a duty of care. What is? But we live in strange times where people seem to care less. What is that duty of care, and why is it so important?
Well, that's a fantastic question. It's a fundamental question, isn't it? I think what society does, if you are a member of society, is you ultimately subcontract me as a psychiatrist to assuage your guilt for that duty of care. You might throw me some money, you might throw my services some money, but ultimately you don't want to hear about it. You want me to go away and take away these patients and take away that concern that you have, because it's very uncomfortable to know that we have people with us who, you know, are not in possession of their full mental senses. They can be violent to themselves or to others that don't possess the degree of capacity or rationality or insight that the rest of us do. So in that sense, I'm being slightly cynical here, perhaps just slightly facetious, just slightly. But I am an agent of the state, and it's the state, Jonathan, that you have, or the British public or the Western public have decided as the stakeholders of the state, this is a system. I just work for you, and you will blame me and throw me under the bus when something goes wrong. This is sometimes how I feel.
But what I mean, okay, here's another way of looking at it. Who are these people? Because, and how am I meant to be around them? I mean, I asked this question. It's quite funny. Where I grew up in a village called Abbots Langley, but on the Abbots Langley was next to Leaveston, and Leaveston was one of the very old Victorian, the asylum, and Frying Barnet wasn't too far away, and that had another large thing. So I grew up with this, but it was on the outskirts of town, and now I live in Brighton, and we've put mental health services right on the outskirts of town again, and I've worked within it, just sort of as a sort of support worker. But how do we see mental health? How do we see these people? What is, because you're working in it, so you see them one way, but you also see people's reactions to them. They've become different, haven't they? There's something about them that's different and a bit unnerving.
But Jonathan, isn't it that we don't want to see them? This is the one thing that I've understood about society, that we don't really want to see them. The conditions we've been talking about today, and it's really nice actually. You started off with mental health means lots of different things, and there's some people doing their wellness videos on TikTok and these kind of things, and then that's one strand of what mental health means. And you're right, you're absolutely right. And then there's this other strand of this serious mental health, serious mental disorder, which is actually called SMI, serious mental illness, which is 1 to 2% of the population. It always has been. It's consistent throughout societies, in different cultures, in different societies. There will always be 1 to 2% who have this kind of serious form of, most often, psychosis or serious mental illness. That 1 to 2% of people we don't want to see, Johnson. Different societies deal with them in different ways. The original ISIS study I was telling you about actually found that people with that kind of serious mental illness did better in less developed countries such as India and Nigeria than they did in the West. This was in the 1970s. This caused a huge puzzle. And it may be, it was hypothesized. And I wonder if this is true, because people with serious mental illness in such countries are still very much part of a family-orientated system or a community-orientated system, especially when you don't have the services and society has to take the shortfall. In the West, we expect our community mental health team, our hospital, our somebody else, the state, to deal with these people. And this becomes a problem, doesn't it?
So, do they have the same issues of violence that we do? Violence towards the self or violence towards the others in these other places?
There's always this issue. I mean, and there's the issues of violence to self, violence to others. There's vulnerability. There's human rights violations. Human rights violations occur differently in different parts of the world. Here, it's quite conceivable that we can just repeatedly detain somebody in a hospital, and there are some checks and balances to that, but there are certainly many cases where we just keep people in hospital and keep giving them medication that they don't want. That's a massive human rights violation. In some cases in India or Indonesia, you will occasionally hear of somebody having been chained in a room, and just being fed through a hatch. You still hear of these cases today.
So, I think there's a room for a separate episode on the role of medication and resistance to medication. I think we do that separately, because I can see it opening up. How should we treat people who have serious mental health conditions?
Tell me something, Jonathan. Is a serious mental health condition an illness or not?
But you described it, you called it a serious mental illness, so you gave it that title.
Sure, okay, I have, but you may not
And if
agree
it's
with
an
me.
illness, what does it mean? If it's an illness, what does that mean?
Come on, you're the sociologist. This
Yeah,
comes from
I'm asking you.
Parsons and all of this, isn't it? If it's an illness, I believe it to be an illness. I believe it to be an illness on some very basic evidence. I know that if I give medication often to treat this condition, it can get better. It's a bit more complicated than that, but there are features of it which are certainly an illness. An illness should be treated. The people who have their condition are sick. They need support from the rest of society.
Then let me ask you a highly
Sure.
controversial question.
Oh, of course.
Do the people who have serious mental illness have responsibility for their own condition?
Does somebody who has gone cycling in London and broken his leg and is now not able to work and is holed up in a London hospital for 6 months while his leg is recovering, does he have responsibility for his own condition?
I would say it depends on the accident. Having crashed my bicycle many times, some of them I was 100% responsible for them. Just acts of stupidity and hitting parked vehicles. Otherwise,
okay.
I wasn't in a good frame.
Yeah, sure.
Of mind.
I'm not asking that question because I want a predefined answer. I'm saying that the way of thinking about it is no different. The answer is actually yes. Some of them, but this is perhaps away from what my job is. Right? My job is not to assign culpability. My job is to treat. But if you're going to ask me my personal opinion, some of them will have, of course, responsibility for their own condition. You have to work as if people want to get well, don't you?
Well, I'm gonna drill into it one more time because when we move into the realm of violence towards others, it'd be nice to know where all this stuff is. So if someone has a serious mental illness, and if society, what should we do with them as a society? What should we be doing with people with this condition? Because if someone's broken their leg, we should be treating the leg and getting it mended again and giving them a bit of rehab, some exercises to do, and making sure they're okay. If someone has a heart attack, we'll do some heart surgery on or something, put a stent in, give them something, a pacemaker. What should we be doing with people who have a serious mental illness?
Well, I think that I'll give you the answer to that question. But what we should do and what we do are completely separate things, isn't it?
So let's start with what we should do, and then we'll do what we do.
What we should do, we should treat it as a condition, as a mental health condition that is often treatable. Psychosis and schizophrenia, these conditions are often treatable, sometimes with varying success, but they're treatable and they're manageable. And therefore, the onus then becomes on us, isn't it? As a society, me as a psychiatrist, but on the whole of us as a society, to ensure that the provision of treatment in terms of the medication, the facilities to support the medication are there. We need to create an environment which facilitates that and does not detract away from that. That can sometimes involve, and it does involve in this country, that appropriate mental health law to define a point where an individual needs treatment or mandatory treatment. I think actually there's a massive debate about this in psychiatry, but I think that is often the most humane thing to do. When we do that in different legislations, in different jurisdictions across the world, we will need to determine a point at which it is important to enforce treatment mandatorily and or under compulsion. And in this country, that is when there is a risk to oneself or to others. And that risk is of what's called a nature or a degree. Where yes,
go on. What's the difference
it's
between a nature and a degree?
Nature is the cause of the condition. It can be relapsing and remitting. It can be episodic. It can be continuous, and degree is the intensity of the condition.
Okay. And
Yeah.
that's what should happen. What does happen?
What does happen is that we stigmatize patients with serious mental illness. We don't want to know about them. We don't give them the attention that they deserve. A schizophrenic patient is much less likely, for example, to have coronary angiography. They're much less likely to have their physical health care needs taken care of. They're much less likely for the GP to spend time with them. They're much less likely to be given a job. They're they're much less likely to be in fulfilled and continuous relationships. I'm not saying patients with schizophrenia don't do all of these things. Some of them do. But essentially, as a society, we stigmatize these individuals, and we don't treat them well. And then, and our services are set up in order to um, manage the worry about society for these people, right? And so there's this whole term of what's called risk management and risk. This whole case that we're talking about, this Valdecalecane case. I don't disagree with some of the conclusions
We'll
that are
come
being
to
drawn.
that. So
Yeah,
what does happen? You had a very important point there. You said we manage patients in order to alleviate the anxiety of society or something like that,
absolutely.
rather than how we should actually be managing them. Tell me
Absolutely,
what
we
that's
we we,
about.
we should be putting the people with schizophrenia at the center of care, and that makes just good clinical sense, Jonathan. And if we do that, if we put them at the center of care, if we're attentive to them, and we are attentive to the course of the condition and the nature of the condition, we will obviously provide them with the best care. But often we're not doing that. We're often treating them because of what it looks like for the rest of society. And this is something called, it's not just in psychiatry, this is something called defensive medicine. We often do that in the medical legal culture of liability that we have found ourselves in. It leads to often poor patient care, adverse outcomes. We're often not treating the person in front of us, but we're treating aspects of what everybody else tells us we should be treating, whether we are influenced by bed pressures or whether we are influenced by reducing the number of the cost of the service, or whether we are only thinking about how it looks in the notes or in the paperwork rather than the actual relationship with the patient. Does that make sense, Jonathan?
That does make sense, and that now takes us into this issue of violence. But I've noticed
Yeah.
we are going to get short of time. So, once we hit violence towards others, there's lots that's going to come out of that. But you've now laid the bedrock for us to be able to talk about it, because I now understand what these conditions could be. I have a rough understanding of it. I understand what that duty of care is. I understand the risk of violence. I understand how when the violence takes place, the medical model it's taking place in, and the societal pressures of the professionals it's taking place in. But I want to give that due time. So if it's okay with you, we're going to finish this episode and we'll pick it up again in the next one. So if you want to follow what happens, subscribe
Of course.
and click on the next one, because we're going to be right back. I'm going to need a break and to make some notes, and then we're going to be right back and we're going to discuss this issue of when mental health creates violence against other people. But now we've got some understanding of it. So if that's okay with me, so I'm going to come back in the next episode to discuss that.
Fantastic. Thank you very much, Jonathan. Thank you for listening and at least taking these matters seriously.
Yeah, that's important, huh? Okay.
Thank you.
Thank you.